Okay. Abbas completed his fellowship in complex gastrointestinal and esophageal surgery at the University of Florida in Gainesville. Today, Dr. Abbas serves as the medical director of the bariatric program and as program director of robotic surgery at HCA Florida Memorial Hospital in Jacksonville. His practice as a leader in minimally invasive laparoscopic and robotic procedures with high patient volumes, he focuses on delivering cost-effective surgical treatments for complex gastrointestinal diseases, surgical treatment of obesity, reduction in opioid use, and the complex impact of robotic technology on patients and surgeons with a thorough and detailed approach. Dr. Abbas is certified in general surgery by the American College of Surgeons. Please welcome Dr. Husain Abbas.
Thank you so much for that introduction, and I'd like to thank President Tim Johnson for having me, and of course, the rest of the Rotarian. So really, I was thinking, I was asking Audette, well, what am I going to say today? And really, as she said, we're really trying to, as you can see, we're one of the biggest healthcare systems in the country, in fact, in the world. And so we are, and most of our hospitals are actually located in downtown communities. So a quick story is very funny is that I didn't know much about Memorial Hospital when I first came, and so when I came, I accidentally landed here. I was supposed to go back up north. I was supposed to be at one of our Yale affiliate hospitals again after I finished my training. When I came here, I liked it. The weather is much nicer than Connecticut, so I figured, you know what, I'm just going to stay here. The last year before I left, I had 5 feet of snow that I had to shovel myself, and of course, they paid a lot more in New York. So guess where the guy I paid $200 on a $2,000 salary went to? He went to New York because they paid him $1,000 to clean up the roads. So I figured, no, I think I saw the light. So I ended up here in Florida. And it's I think where we are, I truly enjoy. I do have a lot of colleagues, a lot of friends who are at a lot of the established Ivy League places, but I feel, as I tell them, I actually do like it when I see my patient that walks in and has to basically make a decision before if they're going to buy the medication or buy new shoes, because they really can't afford it both. And so that's a challenge, and I think that's a challenge that we have nowadays, is that how can we provide state-of-the-art care, but at the same time be cost-effective? Because it's obviously bankrupting the country. I mean, we cannot go in that same direction that we are. And one of the big challenges is that, if we can slide just advance it one more, and we can look at the cost of where we spend most of our actually healthcare budget on. So when we look actually at the top 30 causes of death in the United States, it's actually heart disease, cancer, and chronic respiratory issues. But when we look at the chronic disease in the United States, we actually see obesity and diabetes, of course, and mental health disorder. I'm really kind of going to focus very quickly on the obesity and diabetes. The two are actually interrelated. But the interesting part is that actually we know that obesity increases the risk of heart disease, but also increases cancers as well. And so this is becoming a major cost. In fact, when we look, advance the slide. If we look actually at the So the problem with obesity is actually that it's a complex disease, not a complicated, but a complex disease. It interacts with a lot of other conditions. So what we're seeing now is I have some patients in my clinic who will need a knee replacement done. However, they may actually be overweight and obese. For a long time, what we've had is that the problem has been, we think of obesity as what we see on the outside. We just see somebody who is, overweight. And so what we tend to look at is, historically, it's been kind of like looked at as if it's been kind of like gluttony, inability to control yourself, inability to control how much you eat. And it seems to we think that this is a problem of willpower. That is actually not what we know of obesity nowadays. It's a lot more complicated and complex than that. As we can see here, what happens with obesity is say, for example, the weight increases, the inflammatory markers in the body goes up. So people who are obese will actually have an increased risk of having cardiovascular disease. And that's why when we go to your cardiologist, they're going to check those blood markers to see are they elevated or not. In fact, what we found was very interesting with patients with COVID, because COVID was one of those things that was very strange in that you got a viral infection, but it wasn't treated with antibiotics, because obviously you can't treat that, but it was a pro-inflammatory condition. And what we noticed is that people who had metabolic surgery, they actually had a lower chance of ending up on respirators. So that's when it started elucidating, when we start actually measuring some blood work after you do the surgery. As I said, because the general notion is that it's a lack of willpower, which is completely false, because then the treatment becomes, well, if you can just eat less and exercise, then you're going to lose the weight. There are a lot of people who try to do that, but that's not good enough. And the reason for that is that when we look at the rate of obesity is increasing, and when we look at the actual increase in the caloric intake of everybody, it's not significant. It's not necessarily that we actually are eating more and moving less, believe it or not. It is a combination, but it's also what we are eating. So when you eat a bar of chocolate that has 500 calories, that's not the same as you eating rice and chicken. The two are completely different, even though the number of calories are the same, but the way the body actually utilizes that is completely different. Because the source, the fuel source that you have in the bar of chocolate is obviously not really made for the consumption of the human body. But what that is made to is to actually trigger some of the comfort centers in the brain. So we all know that, for example, when you eat chocolate, it actually triggers the same part of the brain that's triggered by cocaine, literally. The same side of that, what we call the amygdala. So that is the problem then. So it's not a simple willpower. What happens is there are going to be some changes as the weight increases, as the body tries to adjust. Obesity, if you want to think of obesity, is the big chunk of that tree that is probably the cause of most of the chronic conditions that we have. And so we have to tackle that if we are going to actually, live longer, but live healthier. And it's the quality of life that we actually have to focus on. And it's not just the quantity of life we have. And so when we look at obesity, for example, we know that it causes bone and joints issue. That's one of the commonest referrals to my practice is the orthopedic surgeon. And what the orthopedic surgeons have realized is that when you operate on somebody who's obese, two things happen. Recovery is a lot slower, and the complication of knee replacement, hip replacement is actually higher. Even though it still is very low, the problem is that when you have a complication of a prosthetic, it becomes a very big problem. Because now you have a prosthesis, and if it gets infected, or what we gets dislodged, I'll just give you a quick example. So because of the old way of thinking about obesity of just eat less and move more, patients used to say, well, if you replace my knee, then I can move more. I can tell you, I've been doing this for 15 years. I've not seen that happen once. You replace the knee, it does not necessarily help you lose the weight because we're not targeting the root of the problem. So it affects, obviously, mental health, and it's a complicated relationship, but basically what that is, if you imagine somebody who is obviously overweight, walks down the stairs, this is probably a story that I hear once a month. Tears the meniscus because they barely slip, and it's a small slip. Tears the meniscus. Go see the orthopedic, says, I can't operate right now. I really need you to lose the weight. So pain, start getting more pain medication. The weight goes up because now they can't really move at all, and so it becomes a little cycle. And so it definitely will affect your mental health. Cardiovascular, for sure. Diabetes is very common in patients who are actually obese. Reproductive system. I see a lot of asking young females who have PCOS. They'd like to get pregnant, but they can't because their cycles are actually completely out of whack. And that is affecting more and more young patients that I'm actually seeing. heart disease, immune system, digestive system. So we can see that obesity affects every single system in the body actually that we have. And so when we also look at the emergency room costs, this is the cost actually from overweight to obese to what we call severe obesity. The problem is this is not actually the problem only in the United States. So for the first time in world history, there are 1.5 billion people who are actually overweight or obese, and there's only 1 billion people who are actually undernourished. We've never had this before. So basically we have a tipping to one side now. And it's definitely going to increase the cost. And the simple reason for it increases the cost is because, for example, if I have an obese patient, I need to have specialized machines now. I need to have specialized beds. And the reason for that is it may not maintain the weight. So CAT scanners, we've actually have to gone bigger. MRI machines have to become bigger to basically accommodate our patients. And procedures are becoming more and more difficult, and recovery is becoming much and much longer. We know that, for example, when we look at diabetes, specifically in the United States, which is a major cost to the health system, because that's what we call the silent killer. So what you see is I'll see a patient with diabetes when they come to the hospital and they've had a non-healing infection. That's the only time we diagnose diabetes, because all of a sudden we look and their sugars is actually sky high. So when we correlate with the numbers, we can see how actually the number of increase in the new diabetics in 2014 compared to 1994. That's a tremendous cost. We also know that obesity causes high blood pressure, and the increase in cancers to obesity is by about 30%. Why is it so difficult to actually target obesity? It is actually not a problem of willpower, but here's what happens to the body and the system as a whole, is that when you look at a lot of what I call severe calorie restrictive diet, is it simply about calories in, calories out? Portion. That's not the whole story. The reason for that is when you slowly gain weight for whatever reason, then the body's thermostat resets. So your body will not see you, for example, at 250 pounds. What happens when you go on a diet, when you're at 250 pounds, that's been the set point. We are made, from a genetic standpoint, to resist starvation. So we go and die from starvation. For thousands of years, we basically got whatever we could in season, ate it, and that was the calories that we had for that time. So the body is very smart at actually lowering the consumption and making sure that you use whatever you have. When you go on those, a lot of those calorie-restricted diet, you're going to see it even on the ads. You know, just pay attention to the fine detail. It says those results are for the first 6 to 8 weeks, and then it plateaus. And the reason for that is your body then sees minus 20 pounds. You're still, say, from 300 to 280 pounds, but your body does not see that you're actually at 280. It only sees minus 20. When it sees minus 20, then what happens is it will actually slow your metabolic rate to compensate for that. So you will lose the weight, but then it'll plateau. So the way that you can actually target basically obesity, as we can see, it's a multifold problem. It is definitely a societal problem. What I mean societal problem is it's educational in the sense of it's easy to stop by a fast food place, but even places that don't call themselves fast food. The food that we consume has a lot of additive stuff in it that actually changes the way it gets digested and gets broken down by the body. And so that actually affects it tremendously. Some of the changes that people will have to make is essentially not just a simple number of calories. The pure number of calories is not very helpful in guiding you to help to actually lose the weight. The more important part is that some of the foods that we eat consume more. Number one, keeps you more satiated for longer, and it's got to do with the way they get digested. And number two, they actually can consume calories simply by breaking down the same food that you ate, and those are generally proteins. So what I tell people is there's a lot of the health industry is really big and it's huge. Most of my patients, after they recover, because I do metabolic surgery, from the surgery, I tell them, no protein shake, no protein bars, okay? Those are a no-go for me. I mean, unless you're an enhanced bodybuilder on, steroids, that you need to consume all of those proteins, there is no need for you to drink protein shakes. Fruits lately have also gotten bad vibes, they have too much sugar in it. That's actually not true. Eating fruits is very different than when you have a juice. Those are very, very, very different, okay? The way they get absorbed by the body is completely different. When we look at what we call the blue parts of the world, the blue parts of the world is basically the areas where people live longest. So we really look at that and see, well, what do they consume? So number one, I'm glad you all consumed all your food first. Those plates that we have, and a quick story is, I remember when I was still training in Dublin, I came and visited. I used to come here for Christmas every time, go with my uncle. We used to go to Miami. Used to get this Cuban place, used to serve the same thing. I love I love Lydia's rice and beans. And all of a sudden, one year we go, and the portion size literally doubled. And we said, well, what happened, here? And she said, well, basically what happens is all the other restaurants increases the portion sizes, and so we have to increase it. And even though the cost is not much to us, but this is now the new portion sizes. When you look at these countries, it's places like the Mediterranean, specifically area of Sicily and southern Italy. You look at places like Okinawa, which is really an island, isolated island. There are certain parts of China, even though China is getting on the obesity bandwagon now, okay, because of the new food and fast food that's being introduced and the huge migration of people from the villages into the big cities. So basically, they're adopting our quote unquote fast lifestyle, which is kind of mindless eating. By mindless eating, I mean most of us, we eat while we talk, while we watch TV, while we do things like that. So the brain doesn't even register that you actually consume the meal, which is extremely important. In fact, a lot of people will get up and sometimes won't even remember if they actually had their dinner or what they have to get. So those two are actually very, very important. When we look portion sizes, let's show you a fist size. That's the biggest challenge that I have, to try and tell people that you are eating enough and you're not going to die for the amount of calories that you eat. In fact, the more you restrict the calories, the longer you'll live, because that's the way your body's been designed to live, and the healthier you will be in the long run. So we need to change this thing in metabolic rate. So that's why we have, when it comes to obesity, lifestyle and behavioral changes are extremely important. So what happens is, as I said, some patients are at 300 pounds. No matter how much weight they can lose on their own, it is going to be very difficult. The example I always give patients is, what is metabolic surgery? Is it quote unquote the easy way out? It's not. I am telling you, you have to swim from Jacksonville to, Cork City or the west coast of Ireland with two options. You can swim. You can try and swim it all the way from here to there. There are going to be a lot of setbacks, okay? The current will push you back. Or I can take you there, but I can drop you off the coast by about 500 feet. You still have to do the rest of the swimming, because if you don't swim, you're going to get basically pushed back all the way back to where we started from. So that's where metabolic surgery comes in. You're kind of helping people to move them along so they will still have to do the rest of this, because your body will adapt to whatever surgery you do. What we do in metabolic surgery, even though it is what we call changing the anatomy of the body, but the desired effect of that is to change the metabolism of the body. That's what it does. It doesn't simply, you may have heard of sleeve or gastric bypass. It's not necessarily because it makes the stomach smaller that you're all of a sudden losing the weight. It's when you reroute quote unquote things and move specific parts of the gastrointestinal system, you get a change in the way the hormones react. In fact, Ozempic, Zepbound, they actually mimic some of the hormones that are released after metabolic surgery. So that's what they try to do. So the problem with those medications is they actually are effective. One is cost. It's not cost effective, actually, at least not the current charges that, the pharmaceuticals are incurring to the health system. The second part is that once you stop it, you get a very fast weight rebound back. And the reason for that is, it's just like, again, I like to go back to the bodybuilding experience. Just like your bodybuilder on testosterone and all these other, anabolic steroids, once you stop it, that exogenous system goes away, so the muscles just shrivel. And it's the same way that happens. We think that actually the way it works on the gastrointestinal tract, but it also works on the part of the satiety center of the brain. So when that stops, what people describe is all of a sudden the hunger rebounds back pretty aggressively, pretty fast. And so they can't control the hunger, almost cannot control the hunger. They just consistently feel hungry the whole time. So that's part of the problem with pure pharmacokinetics. It's quick fix, but the results could quickly regress as well. So what you have to do is there any way of changing, or at least that's what part of the surgery does, for a specific group of patients, that we can actually help them really almost release their own hormonal response from the inside, almost having an internal Ozempic or internal Zepbound, essentially. The other parts of this are actually extremely important. When you look at the way the body burns calories, most of it is actually at rest. So that's why we encourage everybody to do as much resistance work as you can. Because the bigger the bulk of muscle that you have, if you're trying to lose weight, you should maintain as much muscle as you can. One of the biggest challenges is when people lose weight, they lose lean mass. When you lose lean mass, the effective basal metabolic rate goes down, which basically means you don't need as many calories to maintain your weight. And that's why these diets don't work in the long run. Because now when your lean mass drops, your body's needing that caloric intake with a couple of fruits that you're eating. So, and if you look actually what we call exercise thermogenesis, we all have Apple Watches. They'll lie to you, okay? You're not burning 500-600 calories, and unless you're like Michael Phelps, swimming for 4 hours, because that's a true number of calories that you can burn. But what you want to do is you want to raise that. And also, this actually second one is what's called non-exercise thermogenesis. Comes actually from eating food, believe it or not. So when you change the type of diet that you're eating and eliminating the processed foods, because processed food gets absorbed a lot faster. And so they don't actually consume, the body does not need a lot of calories to break them down. If you can change that, the simplest form of food, if you look at the label of a food, and you recognize most of the stuff that they are actually in your kitchen, as soon as you start seeing all these additives, things like cornstarch, things like glycogenated or hydrolyzed, those are basically things that are only done in big industrial machines. So essentially what you need to do, eliminate those. And this is the biggest challenge, is obviously these are cheaper. And so the options for us, and I don't know how much you're aware, but the food industry probably spends more than the FDA does on knowing how to satisfy your taste buds. They actually do spend more money on it. And the best test subjects are actually not necessarily adults, they're actually kids, because kids will not like you. So basically what they do is they just get kids and they change the number of sugar, the amount of sugar that's actually in that. And then they see, do the kids go back and eat the same cookie or not? Because they're not going to tell you. I mean, you pay an adult, they might tell you, yeah, that was great or it wasn't great, but that does not tell you if it actually, did you hit what we call the bliss point? Too much sugar, you don't like it because it's too sweet. Too little may not be addictive enough. And so that's what they do. And that's what I mean when I say it's a societal problem, because you're really fighting, or we have to change the way we not just think about food, see food, even the amount of food that we eat. And so what we end up doing is basically we end up being reactive. And by that, I mean, well, now that you are obese, this is what we'll have to do. We have to start medication. We have to start doing X, Y, Z. One of the ways we can actually even reverse, for example, something like diabetes is through metabolic surgery. Because once you have diabetes and you're starting on medication to control your sugar, you cannot actually, if you stop that, your sugar will go back up. So it becomes a chronic issue. So what happens next is you have diabetes for long enough, you start getting high blood pressure. So guess what's coming next? It's the high blood pressure medication. Well, you start having that, well, we need to prevent the cholesterol. So the cholesterol medication starts coming up next. So all of it basically adds essentially to us. Now, the problem is that we have a huge number of diets out there, and there's a huge confusion sometimes. Well, what should I follow? And everybody will swear by their own diet. I do keto, I do Mediterranean, I do low carbs, I do high fat, low fat. To me, it's very simple. Can you actually maintain that diet for a long period of time? And here's the other thing. You don't have to stick to that same diet. So for example, generally speaking, we know low calorie diets work in the long run. It will take you time, and it'll take the body time to adjust to that. So when you first start on these diets, you're going to feel hungry after a period of time. So one of the ways that you can perhaps adjust to that would be to do what nowadays people are doing, what they call the intermittent fasting. And all that does is basically you have your dinner, you wake up in the morning, you skip the breakfast, okay? You can have some water. You don't have to have breakfast. You fast for about 14 to 16 hours, but then you have a small eating window period. And in that period, you try to increase your protein intake. And really limit the number of carbohydrates that you're taking. And so essentially, what that does is it will limit the number of calories you're taking, but also will give the rest of the body a little bit of time to adjust its homeostasis. And so this is not a bad way of actually starting. That's one of the ways that you can do it. This keto diet. Well, what is keto diet? It's basically a kind of like a high protein diet. If that works for you, great. What I recommend to my patients, well, do that for a long period of time. But once you get bored of it, find another diet that actually works for you. Because you can always go back to that. If you cannot maintain this in the long run, it is not going to actually serve you well. Again, we have some great medication that actually work. Very effective, very good. Part of the problem is, how do you stop it? If you don't make the changes that we talked about here, you don't make these changes, which are the hardest part of the whole thing, because that really means you have to wake up early to go to the gym, and because we no longer work in farms, we no longer do actually physical activity, we're not as active. And so if you don't change the way you actually think about food, about portion sizes, about, yeah, I'm tired, but I guess I still have to go home and make it chicken, as opposed to just stopping here and having and just buying fast food. Much easier, cheaper, and it says nutritious on it, so it must be nutritious. So this is basically, again, I truly kind of sometimes I debate whether I should be showing these or not. This is great, but this is what we're seeing on the outside. There's obviously a husband and wife that had metabolic surgery, and this is about a year out from them. Both of them lost 480 pounds. That is great, but I tell them the more important part for me is when I look at their blood work. They both had, at this young age, high cholesterol, and they were both borderline diabetics. But after the surgery, when all the lab work normalized, that was to me the great actually win, because that's the most important part of it is, can we get you to be healthier? And of course, as the weight comes off, the chance for them to actually not develop things like osteoporosis, not things to develop knee arthritis or hip arthritis and require knee replacement, hip replacement, is actually going significantly lower. These are, again, one of the biggest problems that a lot of people will not tell you, and sometimes we have to open that conversation with them, is about their weight. It's because they feel they're trapped, and they feel that if they discuss their weight with anybody, and I'm sure, you all look fantastic, so you all obviously watch, what you're eating, but there is that person in the family, or that that one person that perhaps you might reach out and just kind of open that. It's because nowadays we have options. There are options for these people. They truly feel trapped. The greatest thing, they tell me, listen, I've heard this over and over again. He said, did you notice anything about my shoes, Doc? Yes. It's just because I've been done it for long enough. You're wearing laces. You no longer wear those Velcro shoes because they can actually literally bend over and hide their shoes. This will tell you is a great, actually, accomplishment. And also, for the first time, I went into an airplane and I did not feel embarrassed that I was actually nudging the passenger next. So those are the little things. They're really all, I'm just gonna give you time for any questions, but I really want you, if you know somebody, I think obesity has really not been addressed. And a big part of that is we either just don't know how to address it, or we feel, let's just not talk about the big elephant, literally almost in the room, and that's a challenge. I think when you target that, when you open up, when you ask people about that, they will open up to you. And so, like I said, some of us are blessed also genetically. We can gain weight or we maintain, an active lifestyle. We can do that, but some of us are not. They might be prone to become obese genetically. And so I think it's important for us to kind of like approach them and see, and obviously refer them to somebody with that specialty.
Let's give a thanks to the doctor's presentation. When we do have time for 3 questions, I'd like to start the questions off. First, we're going to, Ms. Corrigan, have a question, but you said that portion size is the size of your fist. So you get a fist of mashed potatoes, a fist of roast beef, a fist of bread, and a fist of dessert. Is that what you mean by that, or is it just one fist for everything?
No, so actually that's a good point. So generally, it's actually the fist or the palm of your hand should be the amount of protein you should be having. Okay. Now, if you look at your fingers, that should be the carbohydrates that you should be consuming. Okay. The thumb should be about the size amount of fat that you should be having in every meal, and that should be it. That's all you need.
Appreciate it. Mr. Corrigan, you have a question? No, sorry, I thought you did. I see we have one on the other side coming over, Randy.
I've got a question in the meantime. How much, first of all, outstanding presentation. Dr. Abbas, how much of the cost of healthcare is related to obesity?
So when we look at it, it's about $250 billion. And that includes multiple ways, the medication, the treatments that it's affected, but also a lot of work absenteeism. In fact, when you look away at the work absenteeism related to some of those, my back pain, my hip is flared up, all that's another $100 billion. On top of the 250 that we use in the healthcare to treat our patients. So it's a tremendous cost to the system, to the country. We all basically pay for it, whether we are obese enough, we all pay for it.
You make a great point about restaurants serving bigger portion size now, which are not normal. Like these places want to supersize it for 59 cents more. My question is there much to be said about serving a regular amount on a smaller plate versus a bigger plate? Is that psychologically enough to curb one's appetite?
Correct. The way you do that is, as I said, mindful eating, but we know that if you slowly eat your food, where you chew the food slower, it has 2 functions. So how do we feel full? When the stomach is empty, it releases a hormone called ghrelin. Okay, so that's a hunger hormone. As it fills up, that ghrelin level goes down, but it does take a time. My grandma, probably your grandma, your great grandma was right. Eat slower, you'll feel full faster. And it was an observation that they basically made. And it's true, actually, physiologically, that's true. If you give your body enough time for the stomach to fill and for the ghrelin to drop, you'll actually feel fuller. So you're right. And what we've had in the United States is almost like if they give you a small plate, you go, where's the rest of my money? Stop robbing me. So that's a challenge. And for restaurants, from a cost standpoint, it actually will literally cost them maybe 10 cents more to fill that plate with more food. It will not cost them more. But the cost to the healthcare system is a lot more than that 10 cents.
Good. I think we have time for one more question right here.
What is the tail of metabolic surgery? I know about that, tightening up the stomach and so forth, but even bariatric surgery seems different. Did you just describe
It's the same thing. So essentially, it's the same thing. The reason why I very specifically call this metabolic is the mechanism by which this surgery works. The problem is that we started calling it weight loss surgery. So then the whole focus was like on the weight loss. And if the weight loss was not there, then we consider that as a failure, even though the cholesterol normalized, the sugars normalized, all of that normal. That's the goal. This is not what I tell people. It's not a vanity surgery necessarily, if you want to call it that. It's actually a metabolic health. Metabolic health essentially entails a few things. When your cholesterol goes high, when your sugars goes high, when your body cannot metabolize food in the normal way and keep those ranges appropriate.
We're really excited about you being here. This is a coin, a rotary coin. It's a token of our esteem. Thank you for coming. Odette, thank you for the introduction. One more time, Dr. Husain Abbas. Thank you so much. All right, everybody, we're at the end of our program, and I noticed that Larry Daly snuck in on me. Larry, are you still here? Larry Daly, stand up. Say hi to everybody. Good to see you, Larry. All right, I want to ask you to join me in thanking Tiffany, our banquet manager, and the staff at Timaquana Country Club for outstanding service today. They did a great job. Tiffany and everybody else, thank you so much. Reminder, next week, April 2nd, our greeters are Ali Nicholstein. Our prayer will be offered by John McClough, and the pledge by Harrison Keys. Will do the four-way test. And I can't read this. I don't know who this is that's doing I'm sorry. Harrison Keys is doing the pledge. Michael Bryan is doing a four-way test. Thank you all. Apologize for that. We'll have no lunch meeting on our service week, which is April 9th, and then April 16th, we're going to be out for Easter break. So that means 2 weeks in a row before our Alhambra event. We won't be here, so you need to get out there, buy your tickets, fill up that board for the Alhambra on the 24th. Please stand as Katie Quackenbush leads us in the four-way test of the things that we as Rotarians think, say, and do. Katie? Is it the truth?
We're all concerned. Will be beneficial. Will be beneficial, all concerned.
Thank you all for being here. Forget that. Thank you all for being here. Let's get out and make some magic. Bye-bye.